Thank you for your introduction, and maybe some of you joined us last week when we had more like initiation of MIE therapy and how to individualize. And today, so we will have focus in amyotrophic lateral sclerosis patients, how we can try to manage these patients who can be very challenging. And I hope you have questions, because I will be very, very happy to answer you after the presentation. So I hope you see my screen now. Could you just give me a word, Lea, that you are seeing my screen?
Yes, I can see your screen. It looks great.
Yeah. Okay, good. Thanks. So hello from Norway, Bergen, West Coast. Good morning, America. Here the clock is 4 p.m. and I have been working in my clinics today. Bergen is the second biggest city in Norway, and it's only 400,000 people here living, and in whole Norway just 5 million. So we have much smaller populations than in your country. But I have a long experience, more than 20 years with these patients. So I will also try to share that. Leo has shared learning objectives with you in the Zoom invitation. So we try to come through these things today. Okay, so we have aimed to be a little bit case-based, and I will present you 2 to 3 cases. The first one is Inger. She is retired teacher recently. She's very active with her family and grandchildren. But 2 months ago, she got the diagnosis of bulbar ALS. And she experienced the first symptoms were problems to talk and to eat. And that's her main problem still. She has quite a lot of saliva that also runs out from her mouth, and also problems with secretions. She don't yet have any symptoms for hyperventilation, so she don't have any non-invasive ventilation yet. She is referred to us to try out mechanical insufflation-exsufflation, but it is challenging when we perform a clinical trial. She feels that she can't breathe with the device. She don't manage to coordinate her cough with the device. Her cough is more like not like at this pitch of cough, but more like a long drawl. And she has a sensation of suffocation. And we think this is related with her upper airway dysfunction. So to understand what is dysfunction, we need to understand what is normal function. And I know maybe many of you are respiratory therapists, maybe some of you are respiratory physiotherapists or pulmonologists or other doctors. So I try to give you a short crash course, what is normal function in upper airways. And often we who are interested in lungs and respiration, we think that the lungs are the kingdom in the body. But like all old kingdoms, you had this narrow gate to this kingdom. And in this case of kingdom of lungs, it's larynx, which is on the top of the lungs. And it's part of the respiratory system, which accounts the most significant fraction of total airway resistance. And otherwise, the upper airways, it's not just a tube, which we often add if we run studies with, for instance, with test lungs. We just think upper airways, it is just a little bit narrow tube, but it's not. It's more like a cavity of very different structures, both rigid structures and also soft structures. So keep this in mind. This is a photos above from the upper airways, from the we have passed the mouth and we have come to pharynx and hypopharynx. In the bottom, we see base of the tongue, those bumps over there, and then we have epiglottis. Then you see trachea in the middle and true vocal folds around the trachea. Above the true vocal folds, we have supraglottic structures, aryepiglottic folds, which are quite open when we are having a deep inspiration, like in this scenario on the left. On the scenario on the right, we have a closed larynx, which means that we have vocal folds that have adducted, they are together, and this closure is um, enforced by the aryepiglottic folds who are helping the larynx keeping tight. This is, for instance, situation in Valsalva maneuver when we are lifting something very heavy and holding our breath, or for instance in coughing before we open again. And these photos were taken with transnasal fiber optic laryngoscopy, which is a tool which was initially used by ear, throat, and nose specialists. But later it has also been used by speech and language therapists and also other doctors to inspect the upper airways. And you see here now a video picture of normal breathing. Larynx is opening slightly when we inhale and slightly adducting when we are exhaling. This tool was already used in 1995 by a Belgian group of Jonio. They visualized the upper airways during awake and sleeping in normal subjects who were positive pressure ventilated, and that induced a hyperventilation in these participants. And these researchers wanted to observe and describe how the upper airways are responding to this kind of triggering. And they saw that both in awake and or asleep, these normal subjects had an active glottic vocal fold closure during this positive pressure induced hyperventilation. So the larynx is acting and responding to the therapeutic pressures. A task force group from European Respiratory Society and European Laryngology Society published a statement in 2017 where they describe that there are a condition called inducible laryngeal obstruction, which is an inappropriate, transitioned, reversible narrowing of the larynx in response to some external triggers. It can be, for instance, exercise, like exercise-induced laryngeal obstruction, or like here, it's non-invasive ventilation or mechanically assisted cough that triggers a narrowing of the larynx, NIV-ELO. And we have shown that this tool of laryngoscope can be used during ongoing therapy with MIE. So in our setup, we have two parallel video recordings on one screen where we can observe what happens on the therapeutic device, like here, the old Andersen cough assist device. The green field is positive pressures and the yellow field is negative pressures. And at the same time, when the pressures are applied and changing, we can observe what is happening inside in the larynx. Okay, I hope you are ready. We will see the first video, and that's of one healthy person. What happens in larynx during MIE? And we see when we apply a positive pressure, the larynx is opening. When we ask the participant to cough, do the pressure swing, they manage to do that. And during exsufflation, it's often many openings and closures. And we can also hear that if we had a sound. Okay, so this is healthy, and that's how we started our studies. We started to study just a group of medical students who were healthy and positive to join the studies. It was to examine if the method was feasible, but it was also to try to describe what was normal. Okay, in addition to this, we also saw what other things were normal. It was normal when we applied positive pressure to these healthy individuals that the epiglottis could have a retroflex movement during positive pressures during insufflation. It could be long-lasting retroflex movement like here, or very short, rapid retroflex and then back. And when we applied higher treatment pressures in our protocol, we saw that at the plus 50 centimeters of water, almost half of these healthy volunteers had retroflex epiglottis. So I just want to say, if we started to just examine our ALS patients without examining any healthy, and this would appear in our ALS population, we would not maybe thought that, okay, this is one of the reasons why ALS patients struggles with MIE. But this was actually normal. And we can also think that this can happen in our patients if it's like a normal response. Okay, other thing what was normal. So this is during exsufflation. It can be very, very narrow into hypopharyngeal structures when even the healthy participants are coughing with MIE, negative pressure exsufflation. And again, you see that when we applied higher treatment pressures, like minus 50 centimeters of water, almost so 75% of our healthy volunteers, there were population of 20, had this response. So 15 of 20. More recently, we also have performed another physiological study with healthy volunteers. Here we had examined 10 participants, which was mainly our research group. And we used this fiber optic laryngoscopy with the working channel. And we applied small pressure catheters through the working channel and placed one in trachea, one at the epiglottis, and then we had a pneumotachograph near the mask, which also registered the mask pressure and also the flow. And with this setup, we could describe how the treatment pressures are traveling through the upper airways, both from mask to epiglottis and from epiglottis to trachea. And we also could calculate the resistance in these areas. Okay, so we applied either plus 20 or plus 40 centimeters of water. These were always combined with minus 40 centimeters of water. And these positive pressures, either it was 20 or 40, they traveled quite well through the upper airways to the trachea. So when we applied 20, it was like 16, 17, unless these healthy volunteers coughed and inhaled and coughed actively, it could be quite high, like in some 100 centimeters of water. That was completely wrong, because now I pushed end and it was not right. So I just come back to those findings. I'm sorry. Yes, and those negative pressures. So we always applied minus 40. The participants were either totally passive, they were slightly active with inhaling, exhaling, or inhaling and coughing forcefully together with MIE device. And we saw that we cannot measure these pressures of minus 40 in trachea. So the upper airways are absorbing the negative pressures. And here we have calculated the resistance, both from mask to epiglottis, which we call resistance in upper airways, RUAV, and from epiglottis to trachea, which we call translaryngeal resistance, RTL. And you see from these graphs that the resistance is always biggest during exsufflation, and always biggest from mask to epiglottis, also in those very soft structures. But keep in mind, these are just healthy volunteers, participants who were highly motivated to be tested here. So we go further. What happens in Inger's upper airways during MIE? Okay, she has ALS, she has problems with eating, speaking, and she struggles really to success with MIE when we try it out. Okay, when we examine her, during the positive pressure, her larynx was closing. And when we switched to the negative pressure, it was quite narrow, but it was still a little bit more open. But think when we cannot deliver that much volumes in, and then we switch to the negative pressures, we create more like a vacuum. So it's not that strange that there is a narrowing. And this response, when we, in addition to Inger, we examined several ALS patients, we saw that this response happened either initially at once we switch to the positive pressure or during the 2 seconds of inspiration. And in this study, we had both bulbar ALS patients, which are demonstrated on the graph to the right with red, and non-bulbar ALS patients, which are represented with the blue line. And then we have this black line, which was another new group of healthy individuals, which were gender and age matched to our ALS population. And bulbar ALS patients, this was really, really different response from the non-bulbar patients and from the healthy. So this was the one thing that was very prominent for bulbar ALS patients. Laryngeal closure of area epiglottic folds during insufflation. We also saw that the base of the tongue could go backwards. And this was more prominent if you had ALS compared to healthy volunteers. So either you had bulbar symptoms or not, this could easily happen. We also observed that this hyperpharyngeal constriction, which we already saw with those young healthy medical students, could also happen here in ALS group. It was in different degree, like it was with the healthy volunteers. And in this recent study where we measured the pressures through the upper airways, we had some healthy volunteers who had some closures during our intervention protocol. And when we choose those interventions where the laryngeal closure was observed already in these healthy volunteers, we saw that the resistance measurements were much higher in those interventions where the closure was happening. So we think that even we only examined healthy, the resistance will also increase in these patients who are have ALS and have this laryngeal closure much more often. Okay, say hello to our second case, who is Thor. He is 69 years young man, diagnosed with ALS, spinal onset 2 years earlier. He had been working decades in the bank. He's now retired. He don't have any family, no spouse, no children, but he's very social with his old colleagues and friends. He loves to talk in the phone, for instance. He already had nighttime non-invasive ventilation with nasal mask, and he already have started with MIE 3 times a day to prevent any respiratory infections. And these are based on the measurements we were talking about last week. And before we see Thor again, it's a routine control every third month. He gives us a word that he has some problems with his MIE device. It's not working that well that it was when we started. And we asked him in the phone, but do you have any problems to speak or swallow? He said, no, nothing, just a cough machine, cough device. That's a little bit problematic. And we are wondering, can the upper airways challenge also Thor's MIE use? He is a spinal ALS. Okay, so we have also performed a study where we followed up our ALS cohort up to 5 years with these examinations. We had patients who had spinal onset, and we saw how their laryngeal responses evolved in disease progression. We applied the same protocol, plus minus 20, then plus minus 30, 40, and 50. And we saw that these spinal onset patients also get exactly the same laryngeal closure at the area epiglottic folds during insufflation in their disease progression. And this happens always on the first on the high, with the high pressures of 40 or 50 centimeters of water. But the patients seems to keep larynx open much longer with the pressures of plus 20 or 30. We also tried to map out within our cohort what happens first and what happens last, like bulbar symptoms, bulbar symptom onset, laryngeal adduction during insufflation or during exsufflation, or both insufflation and exsufflation. And we saw that in spinal onset ALS patients, the insufflation gets problematic before they get other bulbar symptoms. So this MIE low might be their first bulbar symptom. And we also saw that the narrowing during exsufflation occurs after the insufflation adduction. Okay, so why this is happening? Why the larynx is closing in both in Inger and Thor? Well, we go even longer back than to the kingdoms. We go to the start of the evolution, when the fishes were crawling from the sea up to the land, and we got evolved a respiratory tract where both the food and breathing are crossing each other in the same organ. It's a little bit tricky, but because of that, we got a larynx that has a main function to stop solids and liquids from entering the trachea and choking us to death already before the first meal of the day, breakfast. And the secondary function is to allow breathing, airflow during respiration, to make sounds of phonation, R, E, and also coughing. So these closures are very old protective functions that are very, very crucial to be functioning, that we are actually be able to not choke us to death. And in my supervisor group, I also have otolaryngologists. And when I tell them, okay, we see that the larynx is closing during the positive pressure, how this is possible? And they say, but Tiina, we use positive pressure to just give small puffs of positive pressure to the larynx to see and test if their reflexes are working well. And when I saw these positive pressures they are using to provoke this closure reflex, it's only 5 centimeters of water or 8 centimeters of water to show a severe sensory deficit. So it's not strange, but for us, whoa, and we didn't know this, and we are operating that much applied positive pressures. Nice to keep in mind. Okay. In addition, Thor and Inger, they both have bulbar innervated muscle dysfunction. That means Inger in mainly, but maybe Thor is evolving that. So the muscles that are innervated from the bulbar region in the brain, like jaw, tongue, pharynx, larynx, are not working well. So when in these patients, these reflexes are not working optimally, and they might not detect what is like more beneficial threat than dangerous threat. It also can be based on physics, the Bernoulli effect, which means that when we push a positive pressure through a narrow tube, for instance, through the larynx, the inside pressure suddenly drops and outside pressure increase the pulling the sides inward, and the structures are actually collapsing. So in Inger and Thor, it can be that the structures are either getting weaker or we are using too higher pressures to provoke this. Okay, can we still help Inger and Thor to use MIE further? Well, based on the observations we have done with the visualization of the larynx with different kind of treatment pressures combined with different kind of instructions, we recommend to first focus to fine-tune the insufflation settings. So to ensure triggering on every insufflation, and maybe you remember from the last week that there was a phasic relationship with the diaphragm and the only abducting muscle in the larynx. So if we activate our diaphragm first, we also open the larynx and creates better conditions for air to enter. And to decrease inspiratory flow, which was also like rise time. So if we increase the rise time, decrease the inspiratory flow, the pressure is achieved not that rapidly. It can be more gentle to pass these very ready reflexes. We can also decrease inspiratory pressure to again deliver the insufflation more mild and not trigger the closure. And in addition to increase the inspiratory time to still deliver the volume we need to cough effective. Here is another study. It's from Spain, Valencia. It's a group of Jesus Sancho, who is pulmonologist there, and they have much bigger cohort than we. They examined 69 patients with ALS. And they didn't visualize the upper airways, but they were detecting waveforms from the MIE treatment. And so they had different settings. They examined the flow curves and together with pressure curves, okay, was it like a good insufflation, bad exsufflation, or whatever. And they managed to detect patients who had mainly problems with insufflations and mainly problems with exsufflation. And with their bigger cohort, they managed to link also these findings if it either was upper or lower motor neuron dysfunction. So the patients who mainly had problems with insufflation, closure, or obstruction, like they describe it, had upper motor neuron dysfunction, which gives more like a spastic paresis. And those patients who had obstruction mainly during exsufflation had mainly lower motor neuron dysfunction, more like a flappy paresis. But who is working with ALS, we know that these patients often have mixed conditions, so both upper and lower motor neuron dysfunction. So it's not that black and white. But this study has again helped us a lot to understand how to optimize the MIE treatment for these patients. And here is one of the examples Jesus Sancho added to his publication. So here we have a flow curve at the top, and then we have a pressure curve on the bottom. And the pressure curve can really help us to understand when the insufflation starts and when it starts switch to the negative pressure and what happens on that part of the flow curve. So in this first scenario, the patient had plus 50, minus 50 with a high insufflation flow, very short rest time, and time settings of insufflation was 2 seconds and exsufflation 3 seconds. Okay, they was not happy with the flow curve, so they changed the settings and decreased the positive pressure to plus 25 and kept more negative pressure, but not that high. It was initially minus 40 They kept the insufflation flow still high, and the time settings was short insufflation combined with longer exsufflation. And with that, they were more happy with the flow curve. We have tried to conclude what helps to optimize the MIE for these ALS patients. Well, if we use lower insufflation flow, which means longer rise time, we create much more stable conditions in the larynx. The pressure is not achieved that abruptly. If we combine lower insufflation pressures with higher exsufflation pressures, we manage to have good conditions in upper airways, at least in some cough cycles, if not in all. If we try to keep a little bit longer break between the exsufflation and the next insufflation, or just take 1 or 2 cough cycles at a time, the patient managed to synchronize the cough much better. If we just have very rapid cycles like insufflation, exsufflation on very many cycles, the patients often start to swallow and it's not working well. To use triggering on insufflations, this phasic relationship which we were talking about, and even a position that is leaning forward. So for instance, if we have Inger, we took her sitting on the table with her elbows on the table and keeping the mask because she had very good function in her body otherwise. And this leaning forward position is also something that helps to open the larynx. Just think about athletes. Okay, have you been following the runners from Tokyo World Championships? They come to the goal and then they lean forward and try to get more air because they need more oxygen after their performance. So this position creates better conditions to breathe in, to abduct the larynx. And we have seen also in our visualizations that in some patients, the oscillations during insufflation or exsufflation can be beneficial. And it's especially with those who otherwise just have the closure, as you saw in the videos. The option with oscillations can be that they have openings and closures, and at least we get some air in, but it needs to be tried out individually. And we individualize the treatment also for Inger and Thor. So Inger, he didn't were familiar with MIE at all. And we understand very rapidly that the insufflation was the problem with the visualization of the upper airways. And we tried to generate a very, very gentle insufflation using low pressures of 20 centimeters of water with the longest possible rise time and having a little bit longer insufflation time of 2.5 seconds. That was combined with minus 40 centimeters of exsufflation in 1 second. And only to say, okay, if you manage 1 cough cycle, it's better than nothing. Or if you manage day 2 or 3, it's better than nothing. Then you keep a small pause. So these patients are coughing differently. Our problem was that we were trying to treat these patients like we are treating other neuromuscular patients. So it was not Inger who was failing MIE device. It was us as a therapists. And we managed to find settings to her with visualization of the upper airways to try to find something that was more beneficial than other things. And we are prepared that we have to adjust the settings again. And this was her larynx, insufflation plus 40 and insufflation plus 20. Same examination, same patient, and you see that the vocal folds are also much more open with lower pressures. Okay, how about our bankier, Tor? Well, so he had originally symmetric settings, plus 40, minus 40, which we changed to plus 30 and minus 45. Insufflation flow, yes, low, longest possible rise time, to not achieve that too abruptly, but we can use 2.5 seconds to that. In that time, that was enough. Okay, but he's a little bit big man, so we could have maybe even a little bit longer time. And very short exsufflation, 1 second with minus 45 centimeters of water. We didn't need to scope Thor. We just used our stethoscope and performed a cervical auscultation here at the throat to hear that we got the airflow in and that we got airflow out. And again, we are prepared that this will evolve. There will be a progression and we will be ready to adjust. So this is just a photo from that kind of cervical auscultation. Okay. Another tool that are often available in our clinics, it's a diagnostic ultrasound. And many of you maybe are familiar already to performing pulmonary lung ultrasound or diaphragma ultrasound. And if you have trained your eyes to see something from these black and white pictures, you probably can adapt that very easily to also perform a laryngeal ultrasound. So I have a PhD student, Anna-Kristina Brecka. This was published last year in Respiratory Care, where we compared transnasal fiber optic laryngoscopy and laryngeal ultrasound, performed both from the front and from the side during NIV in healthy volunteers. And we showed that, okay, yes, you can also see these things with ultrasound, and it's even less invasive. It's more available. So what not to like? Okay, last patient, it's Vivian. Her MIE was initiated when she was quite ill with pneumonia. She felt that the MIE device was just forced to her lungs. It just burned inside her. And it was quite strange to be introduced when she was so sick. But the worst thing was the mucus that was stuck in her throat. And we really needed to adjust the MIE device every day to see what she tolerated. But we got the mucus up and she got well again. But after 1 year in home use, she got problems again. We tried some other settings, didn't work. So we decided to visualize her upper airways. We tried a little bit different devices because we have seen that there are differences from device to device. And we managed to find treatment that was not causing any retching, which was her problem, and she could calmly get help of MIE treatment further. So to summarize, well, so we who love this kingdom of the lungs, keep in mind every kingdom has a narrow entrance, like it from the old days. So think larynx, it's a little bit like a bottleneck to the airways, but it's not passive, it's quite active, like a gateway. And we have to concern it because it's part of the respiratory system. And we can help these patients to extend their use with MIE, with individually customized MIE treatment, not just settings, but also how many cycles and positions. And if we don't know what happens and we're really scratching our heads, we can use visualization of the upper airways during the treatment with flexible laryngoscopy. We can use laryngeal diagnostic ultrasound, if you are familiar with that, or just simple stethoscope to listen to the flow. That could be the first thing maybe to start with. Okay, so thank you for your attention. And I am happy to have questions, and I will try to answer as good as I can. You can also share your experiences.